He actually is the dean at the Sanford School of Public Health at Duke. And he, in 2006, was named one of Time Magazine's World's Most 100 Influential People in a special issue that talked about those with power, talent, or were a moral example of transforming the world. He has published over 15 books, many of which I'm guessing some of us have read. The Learn program, he's written a lot about our toxic food environment. He actually has advised the White House, members of Congress, and governors, and he is very well known. We are very lucky to have him here today, and I'm so much looking forward to his talk.
Well, thank you for the nice introduction, and it's nice to get it from a fellow Dookie. Those of you who follow basketball may know that we're ranked #1 in the preseason poll, so it might be a good year for us. But of course, I'm not here to talk about basketball, but to talk about the obesity issue. And I'd like to say how much of a pleasure it is to be here. And I think when your society connected up with the Obesity Society and created this joint meeting, it was really historic, I believe, because it brought together people who were looking at obesity from lots of different points of view. And if you look at the program for this meeting, you see things all the way from basic biology through multiple types of treatments to public policy and prevention. And it's that joint discussion around those issues that I think will really take us far when we're trying to address this vexing problem. So today I'd like to talk about environmental drivers of obesity and talk about a challenge that I faced in my own work, and I know lots of other people who are researchers have faced as well. And it's how to take information that we collect, either as practitioners or as scientists, and make a social difference with it. And public policy, at the end of the day, tends to become one of the ultimately most important pathways for creating large-scale change. So you could just take surgery, for example. Whether surgical practices and support services that surround that are reimbursed is a matter of public policy. How obesity is considered as a disease or personal responsibility gets enacted through public policy. So getting public policy right can make things good for us all. So I'd like to talk about a model that we've been using around public policy, and hopefully there will be some applicability to the work you do. And no matter what you're trying to accomplish, be it better reimbursement practices or changes in environmental drivers of obesity, I hope this model might be helpful. So, okay, so environmental drivers of obesity. If we look at why we should care about obesity, we obviously know in the US why we should be concerned, but we should be concerned about this problem around the world because rates are increasing in essentially every corner of the world. And if we look at this data showing increasing trends in diabetes, by 2030 we're expecting an increase that looks like this, which is pretty alarming given our high base rate, but in China and India the numbers will look like this. And these are remarkable cases of healthcare burdens to the systems that are not very capable of dealing with it. So we really have to worry about this problem around the world. And when we see numbers like this, it's very hard to blame the problem on lack of willpower, personal irresponsibility, or other personal failings that society often uses to explain the problem of obesity. This is obviously a changing environment happening in country after country. And until we address some of these environmental drivers, we're likely to continue to have high rates of prevalence. It's important that we get food and food systems right. This slide shows the title page from a Lancet article that appeared in 2015 that looked at the leading causes of death or leading risk factors for causes of death around the world. And if you look at the top 10 factors on this particular list worldwide, you see what the risk factors are. And food is involved, if you look closely, in almost every single one of these. Even issues like indoor air pollution, which has a terrible toll on human health and well-being in countries like India, where people are using cook stoves, inefficient cook stoves, to cook food and creating lots of respiratory diseases from the indoor air pollution. So it's important that we get food right, not only for obesity, but for lots of other risk factors as well. So if we're going to address these environmental drivers, what should we do? And how might we go about doing it? So I'd like to share with you a conceptual scheme that my colleagues and I have used over the years that we found to be pretty helpful. Now, generally, when you think about, in the United States, when you think about addressing a problem that is contributed to by behavior, so smoking, alcohol, gambling, high-risk sexual behavior, and obesity, we generally look to doing something to the individual or with or for the individual in order to create change. And so we hope to provide knowledge. So in the case of behavior therapies for obesity, it's all about knowledge. Nutrition education would be knowledge. We hope to provide motivation, in some cases imploring people or excoriating people for their weight in hopes of making changes. And then we can educate, we can implore, and in the particular case of obesity, we can medicate and operate, hope that we have less obesity. So while each of these things is a very important method of endeavor and certainly can be very helpful to people who suffer from the problem, will these things be helpful in reducing overall rates at the level of the society? Are we reducing the number of cases through doing these things rather than just helping individuals? Well, that model that I just showed you is dependent in part on the idea that if people know what they should do, they will do it and the problem will lessen at the level of society. So let's look and see the extent to which knowledge alone helps produce changes in behavior. This graph shows the people in the country get the recommended levels of physical activity from 1986 to 2000. The numbers since then look pretty much the same. During that time, a lot was publicized about the virtues of physical activity. So there can't be many people in the country who don't know it's a good idea to exercise. But the rates look like this. So the numbers are discouraging in how stable they are, but also how low they are. Well, maybe we're doing better with diet. So what about the percentage of people who get the recommended fruit and vegetable servings? Maybe we're doing better with our children. Percent of children getting recommended fruit and vegetable servings. And so you get the picture. There can't be many people, as I said, who don't know that it's a good idea to exercise and to eat fruits and vegetables, but you see what the numbers look like. So there is an environment that's conspiring against willpower and personal responsibility that makes it difficult for people to eat and be physically active in ways that improve their health. So the question is, can you do something about this? And if you look at what we're doing now as a nation, we tend to focus on these things with some exceptions that I'll talk about today. What if you wipe the slate clean and come up with a new conceptual scheme for dealing with this? And in addition to focusing on the individual, could we focus on the conditions that precede the individual getting involved in the decision-making process in hopes of creating a different set of defaults? And I'll explain that in just a moment. So can we change the environment? Can we change things like economics? Can we use legislation, perhaps the regulatory authority of government, in order to create, and now I'm borrowing a term from the economist, optimal defaults? So we're all affected by defaults in our environment, and we hope that if we change these defaults, we might end up with less obesity. But let's use some non-obesity examples for defaults. So in this room, we're expecting to breathe clean air, and we're not expecting the air in this room to make us sick. And we have ceded authority for this to government. And so there are regulations when buildings are built to provide clean air for us. Now we could say that government doesn't belong in that space, that that's big brother and nannyism, and we would have to mitigate the effects of unclean air. We'd have to wear masks, we'd have to do other things like that, but we don't want to live that way. And if you go outside of this room and you get water to drink from the local water supply, you're expecting the same set of healthy defaults. So there are many cases where we give government authority to create healthier defaults for us. And the question is, does this model apply in the arena of food? And let me give you several examples of how powerful defaults can be. Economists have studied people enrolling in pension plans. And as you may know, when employers offer pension plans to new employees, They do it in one of two ways. One way, you're in the pension plan by default. You're given the option of opting out, but you have to take the active step of doing that. In the other case, you're not in the pension plan by default, but you have to take the active step of opting in. So under both sets of circumstances, the employee has the same set of choices. You can opt in or out, but boy, does it make a difference what the default is. And here's how the data look, that if the employee has to take the active step of enrolling, you get enrollment that looks like this. If there's automatic enrollment, it gets nearly to be 100%. A pretty impressive phenomenon. Here's a health example, organ donation. In this very well-known study done in Europe, investigators looked at the percentage of people in the population who agreed to be organ donors. To the left of that white line, you see 4 countries, Denmark, Netherlands, UK, and Germany, that use the US model, where you are not an organ donor by default. You have to opt in when you get your driver's license. And you can imagine what's coming to the right of that line, which are countries where you are an organ donor by default, but you can opt out. If you use the US model, you get organ donation rates that look like this. If you change the default, you get this. Now these numbers take my breath away. I mean, how in the world could you get 99.98% of people to do anything? Well, you can change the default. Now you could try to educate your way or implore your way from the left-hand side to the right-hand side, but think how much money it would cost, and you would never get anywhere near to those blue bars. Or you can do something simple that doesn't cost anything by just changing the default. So this can be a very powerful way to approach things. And again, the question is, does this apply into the field that we care about? Well, if we look at what food and physical activity defaults are in the US, you see a pretty terrible set of circumstances. I won't talk too much about physical activity, but if you think about how physical activity has declined and energy-saving devices are preventing us from being physically active almost every step of our life, how physical activity has been removed from schools and all these sort of things, it really has made a difference. But there's also been a profound change in food norms, and one can look at this different ways, but just some of the changes are food norms that create what we might call toxic defaults. And here are just some of the examples, not a complete list, but a partial list. So when I was a boy, nobody ate in their automobile. And now, if you're a car maker and the cup holder isn't big enough for the large cups, you lose market share. When we eat has completely changed. I don't know, it might have been 25, 30 years ago, one of the fast food restaurants declared that they would begin serving breakfast. I don't know if it was McDonald's or Burger King. People thought they were crazy, that Americans would be so incensed by the mere thought of this that they would boycott the restaurant and it would go out of business. And look where we are today. Some of you may have heard that since the fast food industry has captured the early morning hours, they're now working hard to capture those hours very late at night. Taco Bell has called this explicitly the fourth meal, that meal between dinner and breakfast, when it's not only okay to eat, but it's okay to eat fast food. And then we can talk about how much we eat, what's acceptable. And then the last item on there is the percentage of calories that humans are consuming, Americans especially, in liquid form has gone up dramatically over the years. And people tend not to recognize calories and feel satiated when they're consumed in liquid form. So this is a real concern, and one of the reasons why sugar-sweetened beverages have become a target of public policy proposals. Now, one can talk about who's responsible for changing these food norms, and it's a complex picture, but the fact that they've changed doesn't require much of a leap of faith. We can just scroll back to our childhoods and see how things have changed in a relatively short period of time. So if we're going to change defaults, how do we go about doing it? Can we change some of these circumstances that are driving people to eat more? Low costs of unhealthy foods, higher costs of healthy foods, high levels of access to unhealthy foods, and food deserts for some of the people most in need in the population, portion sizes, the marketing of foods, etc. If we're going to change that, how do we go about creating this change? Well, here comes public policy. And the question is, how effective is public policy being, and how can we best create positive impacts on it? As you all know, public policy is a complicated thing. There are a lot of players involved. Some of them listen to scientists, other ones don't. And it's a little hard to know how to best move ahead. And so one of the challenges that I faced in my own career as a scientist is doing work that didn't seem to make much difference. And then I'll talk about a model that we've used to try to create change, more of a change than what we were experiencing before. So as scientists, we always hope excuse me, that we're producing knowledge that helps serve society. But does society actually get served? That is, we produce knowledge, to be sure. We're publishing things in journals and books and papers. But how much difference does it really make? And the question is, what lies in between the production of knowledge and society being served that we need to pay attention to, but now don't? And so a key purpose of our work is to focus on that middle box. So the frustration has been that research tends to reach pretty small audiences. Some of you out there are scientists, I'm imagining, and you may be aware of the phenomenon that I experienced earlier in my career, that you'd write papers, a very small number of people would read them. I mean, you might be able to count them on one or two hands, but those people then tend to reinforce each other. They cite each other's articles, they invite each other to meetings, and you get this sense that you're making a big difference, but it's within this very small contained group. And whether that knowledge makes it into the outside world in any way can be questioned. Research very often misses the people who might be able to use it most to create change, and that leads to these poor links that we hope to address. And the metaphor that I use to describe this is the running of a relay race. So if you're in a relay race, you have to pass the baton successfully from one person to the next in order to be able to complete the race. And if you drop the baton, you're disqualified. Now, when we as scientists produce information, we have this sort of mystical wish that somebody is going to take the baton from us and use the information to create change. And it's not surprising that we have that mystical wish, because we all want to do good in the world, but we're not trained in a way to create change. We're not trained in it, we're not reinforced for it in academic settings, and so it typically doesn't happen. Once in a great while it happens, almost by accident, but it doesn't happen in any systematic way. So the question is, can we make a successful pass of the baton and do it in a systematic way? Now, when our research doesn't have the impact that we hope, we typically blame it on the outside world for being too stupid or inattentive or just not caring about science. In some cases, we attribute it to anti-scientific bias among some policymakers, but in other cases, we just don't think they're smart enough to understand how great our work is, and therefore it's not making enough of a difference. But let's just say, for example, that we were setting out to make science as least relevant as possible. Now, of course, we wouldn't do that, but let's just say we were. Well, what would we do? Well, first, we'd make it really slow. It would take a long time to get research funding. It would take a long time to do a study. It could take several months just to get approval to do the study. And then once you do the study, it takes a while to write it up. Then you submit it for publication, and that becomes a black hole that can sometimes take a year or more. So while the policy world is just moving snap, 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 we're moving at a glacial pace. We would communicate it only with our fellow scientists and not with the people who could make a difference. It would be unresponsive to real world needs because we're just talking with each other. And so we define what the next important study is based on science, but not on the real world. It becomes programmatic rather than strategic. I'll discuss that in a moment. There will be conflicts of interest galore with money coming from affected industries, and we will create indecipherable jargon in which to describe our work. So just think of my own field of psychology, for example. Instead of just calling something symptoms, we call it symptomatology. You know, there's no ghastly reason for doing this, but this is the sort of thing that we do. So we, in fact, do all these things extremely well. So how can we expect the baton to be passed when the policy world moves so quickly? So here's how we went about trying to address this fundamental problem. And what we did was to think about how research is creating social and policy change. And we found that we were pretty good at this, but not very good at the social and policy change part of it. So we created a model that looks like this. We looked to pay attention to that middle part of this process and created a conceptual scheme that is captured in this slide, that research can affect social and policy change through certain change agents. And the question is, who are these change agents? Who are the people or institutions in a position to do something about our problem? And can we communicate with them in this nice feedback loop that provides a link between the research and the policy, but also provides a way for policymakers to inform the research that we do? So in the case of obesity, for example, legislators obviously come to mind, but also the heads of regulatory agencies are incredibly important. Think of the USDA, the FDA, the FTC, et cetera. And these agencies have state equivalents, in some cases even local equivalents. And do we interact with them? Well, not very much. The courts can be really very important, and the judicial system. So think, for example, of how powerful the state attorneys general were in addressing the tobacco problem by suing the tobacco companies. And there could be some very interesting authority for the state attorneys general in our particular area of interest. The press can be very important in helping drive public opinion that then creates the groundwork for public policy to change through the public opinion as I have here. NGOs can be very important, and industry, of course, is a very important player. So the model that we hope to create, I'm going to give you these particular examples, looks to create a virtuous cycle of solutions by first identifying change agents. Then that helps us craft strategic research questions that then we can do in the laboratory or outside in the community. And then we try to communicate that information back to the change agents, and that creates, we hope, this virtuous cycle. And so I'd like to give you several examples of this, but before I do this, I'd like to say that this model is communicated in this paper that I wrote with colleague Christina Roberto, using this model of what we call strategic science. So in addition to programmatic science, which of course is very important for our field, can we do strategic studies that help affect public policy? So case study number one has to do with menu labeling. You may remember that New York City was the first jurisdiction to put a regulation into effect to create the mandate for restaurants to put calories on their menus. And this was chain restaurants primarily, the regulation applied to. The city got sued twice by the industry, but prevailed in the courts, and then the regulation went into effect. So to the extent you think this is helpful public policy, the question is, if you get an early adopter and somebody goes first, how can you encourage or help others go second, third, and fourth, and then you get something that could happen on a much broader scale. So after New York took action, Nashville, Miami, Philadelphia began to consider this, and the state of California did. Having the state, of course, pass the law is much better than trying to do it city by city because so many more people would be affected. So California was important. But Governor Schwarzenegger, at the time this occurred, said that the only way he would sign legislation was if the public health community and the restaurant industry could come to an understanding about what the law should look like. And one of the concessions the restaurant industry wanted in this process was to exempt drive-in windows from the need to have the calorie information posted. Now the industry said that they wanted that it would cost them an awful lot to put in bigger boards that would have the space for the calories. That didn't seem like a very reasonable argument because they could easily afford a board that's a foot wider and have the calorie information. But that's what they said. But it seemed to me that a lot of people go through these drive-in windows and that you might miss a lot of customers if you gave them this exemption. So you see things like this of people waiting in long lines to go through the drive-in windows, but I didn't know how many there were, but I thought it would make sense to find out. So I heard about the California example one morning at about 10 o'clock, and I canceled some noon meetings and got a clipboard and sat across the street from a McDonald's in my car, and I counted how many people drove through or walked in. Now, it wasn't science, it was just me and my clipboard, and I might have mistaken a dog in the front seat for a customer, and there could have been all sorts of error in my method, but my little informal assessment that took me a couple hours to do showed that about 60% of people were driving through rather than going into the restaurant. So then, my graduate students agreed to take on this issue and do a proper study. So they did thousands of observations. They did it at different restaurants, different times of day, in different parts of the area where we lived in Connecticut, and published this particular paper on it. And it turned out that when you did the proper science on it, it came in just under 60%. So this wasn't high science by any standard. It took a couple weeks to do, might have cost $50 for some clipboards, but it was well done scientifically, enough to get published in a journal. But it made a big difference in the discussion around the public policy of menu labeling, because in California, in their discussions, did not grant this exemption because we gave the numbers to them. And then place after place, including national legislation that will become effective soon, is not granted that particular exemption. So this came about because of the discussions we as scientists were having with people in the public health community, the NGOs who were working on this particular issue. So this would be an example of strategic science. Here's another example around children's food marketing. When I was at Yale University and involved with a center there called the Rudd Center for Food Policy and Obesity, which has now moved to the University of Connecticut and continuing to do outstanding work, we received money to study the marketing of food to children. And my colleague Jennifer Harris led up an outstanding group of researchers to understand the ins and outs of food marketing. They studied how much marketing was being done, who was being targeted by it, and what impact it was having on children. The first report that got released was this report on the marketing of breakfast cereals to children. Now, this report has loads and loads of data, but I can distill it into a pretty understandable set of numbers. Think for a moment of creating a list of all the breakfast cereals that might be marketed to children and rank ordering them on nutrition quality, with the worst cereals at the top, the best ones at the bottom. The worst ones would have the least fiber, the most sugar, etc. And then the best ones would have the most of the good and bad nutrients. And then next to it, you put a list of what's marketed most aggressively to children. And let's see the extent to which those two lists coincide. So here are the best dozen cereals by nutrition scores. And let's look at how much marketing is done through TV, through advert games, an internet phenomenon, and through other youth websites. And it came to exactly 0. So if we take the worst dozen cereals by nutrition score, and you see what they are here, let's look and see how much marketing is being done to children. And then the list gets populated pretty quickly. Now, the companies all have healthier products in their portfolio, but they're not marketing them to kids. So the question is, why would this be? Now, you can probably guess, but let me tell you the conclusion we came to. So when we were about to release this report, we figured that the press might be interested, and in fact it turned out to be. It got an awful lot of attention in the press. And we were hoping that this might help persuade the public that something ought to be done about this, and especially raise the ire of parents whose children were being targeted by this information. We tried to predict in advance what the industry's defense would be when they were faced with these results. And it wasn't too hard to guess, because we'd been on panels with people from the industry, but also this very interesting paper came out, published by the leading nutrition figures for two companies which are otherwise highly competitive with one another, Kellogg and General Mills. And they were writing about children's breakfast cereals. And this was a statement made in the paper, that food doesn't become nutrition until it's eaten. So the idea there is that if a cereal sits in the bowl and the kids won't eat it, it's of no value to them nutritionally. And then also in the paper, children like the taste of ready-to-eat cereals. Ready-to-eat is a euphemism for high sugar, and are therefore more likely to eat breakfast. So the industry's defense, we figured, would go like this, that they would say, point number one, eating breakfast is a good thing. Well, science supports that. Number two, that cereals can be a good way to deliver nutrients. Also true. But number three is that unless a cereal has a lot of sugar, children won't eat it and the nutrition goes unconsumed. So this, to us, was a testable hypothesis. You could, let's do some science on this and see if they're right, because then that would help us address what we thought their chief defense would be. So we did a study, led by Jennifer Harris, who I mentioned before, on the consumption of breakfast cereals in children. And Jennifer and the colleagues working with her randomly assigned children to two types of breakfast. One, they were given low sugar versions of a cereal, like plain cornflakes, and the other, they were given the higher sugar version of that same cereal. And then the children could add as much milk as they wanted, pour as much cereal in the bowl. They could add sugar if they wished, and they could also add fruit if they wanted to. And what we found in this study is that children who got the lower sugar version of the cereal ate just about what you'd like a child to have for a breakfast. And to sweeten it up, they put fruit on it, so they got the nutrition boost from the fruit. The children who got the high sugar version of the cereal had a much worse nutrition profile for what they ultimately ate. And so it seemed like we had done a successful test of what the industry was going to challenge us with. And so we released our results, and then when the press would call the chief people at companies like General Mills and Kellogg and say, why are you marketing your worst products to children so aggressively? And the companies then would go through that three-stage logic model and say, well, kids won't eat it unless it has a lot of sugar. We had this study to contradict that. So it became very strategically important in that particular context. Several months after our study got released, General Mills announced it was going to reduce the sugar in its children's cereals by 25%. Now, we can't begin to take credit for this, and so I'm not assuming there's any cause and effect relationship, because a lot of people have been working on this topic for a long time. But to the extent our study or other similar studies might have been influential, it might have gone through this kind of a process. That we did the research was communicated to the press, that helped shift public opinion, and those in turn might have led to the industry change, which then created the important social change that we were hoping for. Now think for a moment if you were trying to educate our way to a 25% reduction in the sugar kids are receiving from cereal. It would take forever to do it and cost an absolute fortune, and you may not accomplish the goal. But this is something that could be done by changing defaults, and the default here was the way the industry is formulating its products. So this is just the beginning of change that the industry may make, but it was a positive one, and we were very happy with this, and we did that strategic piece of research to help address this issue. Let me give you case number 3 of strategic science: high consumption of sugar-sweetened beverages. As you know, there's grave concern about how much sugar people are consuming through sugar-sweetened beverages, and a number of policies have been enacted to try to help address this, like getting rid of these products in schools and more recently taxing these particular products. So why focus on sugar-sweetened beverages? Well, there's a very long list of reasons, and the science of this has been well worked out now. So the science linking sugar-sweetened beverages to negative health outcomes is quite robust. And the addictive properties of sugar is a very interesting topic. If any of you are interested, we could get to in the question and answer period. The gratuitous addition of caffeine that keeps people coming back for more is interesting. But let me focus for just a moment on the third bullet point, the poor calorie compensation. So, as I mentioned earlier, the body doesn't seem to recognize calories as well when they get delivered in liquids. And therefore, you don't feel as full and you're likely to overdo it. So let's say we did a study with the people in this room. We divide the room in half. So on the experimental day, people on this side of the room get what you ordinarily have for your lunch, whatever that is. But you get an additional 200 calories, but those calories come in pizza. It could come in pizza, donuts, or ice cream for that matter, but it's not in a liquid form. And then this side of the room, you get whatever your normal lunch is. You get an additional 200 calories, but you get them in sugar-sweetened beverages. And then we follow you as you're eating ad lib later to see whether you've recognized that you've overdone it and you cut back voluntarily in order to compensate for the additional 200 calories. The people on this side of the room will do better than the people on this side of the room, and hence the constant consumption of sugar-sweetened beverages, which is a reality for many parts of the population, lead to excess weight gain. So one of the proposals to address this are taxes on sugar-sweetened beverages. And one of the reasons, again, to focus on the beverages are that the biology of these things have all been worked out, and this paper describes this in great detail. But one of the policy proposals that I and others have worked on for a number of years are taxes on sugar-sweetened beverages. The argument in favor of this goes back about 25 years now, but the idea didn't really catch hold until about 2009, when several things happened. First, the research on sugar-sweetened beverages became quite robust, and there was scientific consensus that something should be done about this, and policymakers were beginning to agree. Taxes became part of the picture in 2009 because the economy was so poor in the United States, and legislators were looking for ways to raise revenue, and taxes became one possible way of doing this. And some were very interested in lowering healthcare costs, and reducing sugar-sweetened beverage consumption would become one means for doing that. So this paper I wrote with Thomas Frieden, who at the time was the health commissioner of New York City, he's now the head of the Centers for Disease Control and Prevention, made a public policy case for putting a tax on sugar-sweetened beverages, and in particular we argued for adding a 1 penny per ounce tax on any beverage with added sugar. In that same year, I wrote a paper with a number of colleagues, medical professionals, economists, and others, making a case for not only addressing this from a public health point of view, but from an economic point of view. As you know, economists who believe strongly in the free market say that you don't interfere with a business transaction between a seller and a buyer unless certain conditions are met. And among those conditions that justify government intervention are externalities, and that's the case where an individual not involved in that transaction between seller and buyer is affected by it. So secondhand smoke would be an example of an externality. And in the case of sugar-sweetened beverage consumption, the population is paying the cost of obesity through things like Medicare and Medicaid, and so the costs to us all become an externality. And there are other economic arguments as well. So we supported that call for a 1 penny per ounce tax on sugar-sweetened beverages. We then set out to do strategic research that we thought might be helpful in this context. And we talked with policymakers and said, if you were to ever consider this, what kind of information would you need? And that helped us define a research agenda, which we then undertook. And I'll give you examples of some of those studies. So the first thing we did was an effort led by economist Tanya Andreeva to establish the elasticity of beverage consumption given price changes. And what that means is you could predict, using models, of how much a certain level of tax would affect consumption in the population. So then legislators would know that if we put in a tax of this amount, it would produce X amount of change in the beverage consumption, and then you can model the health impact of that reduction. So we had these numbers worked out. Then Tanya Andreeva did a subsequent study looking at the revenue generating potential. So for the legislators who were interested in doing this tax, because it would generate revenue that could be used for important programs, they needed to know how much a tax would generate. And these numbers became really very important in the discussion. Then the Rudd Center created a tax calculator where you could go in and enter any city, a major city or state in the US, and put in a tax amount, let's say a penny per ounce, and it would generate an estimate of how much revenue could be raised for that particular locality. So if we take the state of North Carolina, for example, where I live at the moment, it generates a table that looks like this. And the most important number is the one on the bottom right there. So the state of North Carolina, if it put into play 1 penny per ounce tax on any beverage with added sugar, would raise $453 million a year. And we have a medium-sized population in our state, so you can imagine New York, California, Texas, Florida, or the other cities with higher populations. This is enough, $453 million, to do a lot with. And so for the legislators who ordinarily might not like the idea of taxing things, the prospect of using this revenue for something became very important. Now, there are 3 interesting players in recent political history for whom these numbers became important. The person on the top of this picture is Michael Nutter, the former mayor of Philadelphia. The person on the bottom left is Don Schwartz, who was the health commissioner of Philadelphia. Tom Farley is now the current health commissioner. And the person on the right is Mayor Kenney, who's the current mayor of Philadelphia. When Mayor Nutter was in office, he was talking with the health commissioner. This is what I heard from the health commissioner. And was ruling the fact that the city had a big deficit and also the fact that there were big health problems, and brought up the issue of obesity in particular. And Health Commissioner Schwartz said, I want to show you something, and brought up the website that had our tax calculator, and then put in Philadelphia and showed how much revenue could be raised from a tax. And then also talked about the health care savings that would occur from a tax because of decline in sugar sweetened beverage consumption. And the mayor became very interested and then became a champion for a tax. Pushed very hard for a sugar sweetened beverage tax in Philadelphia. The beverage industry swept in and spent many, many millions of dollars trying to fight this. There was a lot of political intrigue, and at the end of the day, the proposal to do this was withdrawn by the mayor because he thought he was slightly short of his ability to get this passed in the city council. But it came close, and that was interesting. Then along comes Mayor Kenney, who proposes an even higher tax than what Mayor Nutter had proposed, but had a whole different rationale for it. Instead of focusing on the health benefits, he focused on the use of the revenue, and said he was putting this tax into effect to fund early childhood education programs and some other things he said the city desperately needed. The tax is now passed and is in effect. He proposed a 3 penny per ounce tax on every beverage with added sugar. They compromised at 1.5 pennies. So you can think about this. Think of a 1.5 penny tax on a 2-liter bottle of soda. You know, the 1.5 pennies times 64 ounces, the tax is going to be more than the cost of the soda, and that now applies in Philadelphia. Berkeley has passed a tax. There are taxes in France, in Mexico, in a number of Pacific Island nations, and lots of other places around the world. So, and the taxes are being considered in many other places as we speak. Cook County, Chicago is one example, but there are many others as well. So the idea of a tax is starting to take effect, and it was our hope as scientists that we would be able to do strategic studies in order to help that argument along, to inform the policymakers in ways that were important to them. So those became a series of strategic studies. So going back to our original model, it looks like this. We identified the change agents, a mayor, a health commissioner, it could be a governor, it could be the head of a state agency, it really could be anybody. But before we do our science now, we always talk to these people. And we ask them what information would be helpful for you in your desire to change the drivers of obesity. And they don't come up with research designs, of course, but they're very good at identifying information gaps and information that would be very helpful in proceeding down the road. That lets us develop these strategic questions. We then do our research, and then we can communicate that right back to the policymakers. So this has been a model that's been very helpful and interesting for us to use, and we hope helps correct that problem of science not having an impact on public policy as much as we might like. So one question that sometimes gets asked is, should researchers be doing this kind of stuff? Because it could start to sound partisan or biased in a way that if you go into this hoping for a particular outcome, then doesn't this represent bias? Well, we hope that we don't go into it with hope for a particular outcome. We want to provide information So when we did the study with breakfast cereals, or the number of people going through drive-in windows, we had no idea where the data would take us. We were committed to publishing the results no matter what we found. We happened to find what we did, but we hope we go into it in an unbiased way. And peer review through the publication process is one way of helping protect against the bias. But the question still arises, should researchers be doing this at all? And I'd like to introduce you to this person. Some of you may know who he is. I'll tell you who he is in a minute. But he's a very interesting case of a researcher doing just what we've talked about and making a big difference in the world. He became interested in a particular type of malnutrition in developing parts of the world, and he was interested particularly in vitamin E deficiencies. He began studying this, looking at the impact of vitamin E deficiency, especially on children, and found that there was a heavy healthcare cost from this particular deficiency. So he did some of the initial basic studies proving the links between vitamin E deficiency and negative health outcomes. Here's who he is, Al Sommer, who until several years ago was the Dean of the School of Public Health at Johns Hopkins University. So in the 1970s, he documented the link that I just described, and then he did small studies of supplementation, randomized trials of giving some children the supplements, some children not, then looking at health outcomes, and found very beneficial effects. He then worked with policymakers to try to get the supplementation done on a broad scale, done country by country by country. And now this has been done in many places around the world. And so they have found in this research that for 50 cents annual cost per child, that $100 gets returned in healthcare savings. And look at these numbers. A million deaths a year saved by this research. Now what if Al Sommer had only done the original study showing that there was a deficiency in vitamin A that led to these health outcomes? And that's all he did. The baton would have dropped. What if he'd done the supplementation trials and found that there were benefits from supplementation, but stopped there? The baton would have been dropped again. But he didn't do that. And look at the difference that he's made in the world. So yes, researchers can do this, and I think researchers should be doing this. We need better training, we need support within universities in order to accomplish this, but there are a number of examples of it working. So I'm going to end with this particular slide, going back to the concept of changing defaults. Are we making progress on this? Well, we sure are. And here are just some of the examples. So there are laws in effect now that change our information defaults. You may know that the Nutrition Facts Panel on food packages will contain information on added sugars now, thanks to work of the Dietary Guidelines Committee. Calorie labeling provides nutrition information, and people in certain states, especially California, are working on warning labels for products like sodas. Economic defaults are changing. Soda taxes are now in effect, as I said before, in a number of places, and there seems to be increasing momentum for those. And wouldn't it be wonderful if one of the policymakers was able to pass a law that linked the income from soda taxes to subsidizing things like fruits and vegetables? Then you get a double benefit there. And of course, there are access defaults. And the first frontier of this were policies in schools getting rid of junk food and products like sugar-sweetened beverages. So these have been big changes. People are working on food deserts, changing portion sizes, providing a better set of defaults for physical activity. There was a while back when if you looked at the press coverage on obesity, it was all about whose diet was popular. It was Dr. Atkins, it was the rotation diet, it was the Beverly Hills diet, the Scarsdale diet. But implicit in that message was that it's your fault you're overweight, and you better find the right diet, and we're going to tell you which one it is. Now if you look at the press coverage, that's almost disappeared entirely. And now it's about what policies are being put in place. And hidden in that policy debate is this concept of defaults. If we can change defaults so that healthy choices become the easy and normal choices, then we have some hopes of reducing prevalence. So addressing obesity through treatment is absolutely necessary. It provides help for the afflicted. And thank goodness those of you who are working on treatment are doing what you do. But we're helping people one at a time, and when we look at the overall numbers for the whole population, we just don't have enough treatment to reduce that number. So we have to think about prevention, have to think about these environmental drivers and how to go about changing those. And I hope that our model of strategic science is an interesting way to think forward about this. So thank you very much for coming, and if we have time, I'm happy to answer any questions.
Any questions from the audience? And I know I have a couple, Dr. Brownell. First of all, excellent talk, and thank you very much. It certainly is a different way to think about it, because most people here, at least in the bariatric world, are working at care centers that are treating people that are afflicted with obesity at the more extreme levels. And on a policy kind of a standpoint, as I think about it, the access to care for bariatric surgery is limited because of policy issues related to insurance carriers. And it makes me think about how it changes and how we as professionals in the bariatric world really need to communicate with insurance companies. And we've seen lots of changes in North Carolina, for example. They go with different insurance requirements, not clinical requirements for having bariatric surgery per se, but what the insurance company wants our patients to do. Do you have any thoughts or recommendations how we can work with our partners in insurance to help this become a different sort of policy issue?
So thank you very much. I'm glad you asked the question. I'm not expert on that particular topic, so I can't comment on information that can be provided, but let's look at our strategic science process. If you or others were to say, who are the people who are going to be making those decisions? What institutions and what players? Are they in government? Are they in the insurance industry? Where are they? And then go talk to them and just take them to lunch or go meet with them. And people are surprisingly willing to have these meetings. And then just say, what sort of information would be helpful to you? Is there some bit of evidence that would persuade you that this is an important thing to do? And then we can provide that information. So instead of continuing to read new studies that have kind of been done before, we might end up doing new studies and providing new information that would help with that particular debate. Getting a public opinion poll might be helpful, for example. If the population likes the idea of these sort of interventions, once they're a little more educated on it, then that might help persuade policymakers. The policymakers might say, well, I'll vote for it if my constituents believe in it. And then the question is, what is public opinion? That information might be persuasive. So finding out who the decision makers are, meeting with them, trying to find out what information is important in their world, then can lead to some strategic studies that could be helpful.
Thank you. Looks like we have a question.
Hi, Maya Buddy-Bailey from the University of Rhode Island. I really enjoyed your talk, and I'm very much a public health advocate. But one question that I have when I think about this work and these strategic partnerships is, what about the unintended consequences? You know, you think about the fat debate for a period of time and how that led to low-fat marketing and introduction of things that we now know are not particularly associated with good health. So how do we kind of think about some of those externalities as well when doing this kind of research?
Right, so it's a great question. Certainly you want to anticipate and prevent unintended consequences as much as you possibly can. You can also get paralyzed by the fear of them and not do anything about anything, so of course you don't want to do that. So the question is, what's the middle ground? And to me, the middle ground is you use the best available science. If there are consequences you can't anticipate, you want to know what they are and study them so you can ultimately do cost-benefit analysis. But you want to do evaluation once these policies kick in. And the beauty about the soda taxes is that there was, in Mexico, for example, there was in Berkeley, they passed a tax recently, there were evaluations in place before the taxes ever went into effect. So good baseline data were collected in a fairly short time after the the policies went into effect. We had good data on whether they were effective. So for example, an unintended consequence of a tax on sugar-sweetened beverages could be that it's a regressive tax and unfairly hurts the poor. Well, you can test what effect it has on different segments of the population. That's now been done. An unintended consequence might be that people switch from the beverages that are taxed to equally caloric beverages that are not. That would be an unintended consequence. That can be studied. So that's why it's so important to evaluate these policies. And some players like Robert Wood Johnson Foundation and the Bloomberg Foundation have been especially helpful in providing funding to do just that kind of thing.
Thank you.
Thanks very much.
And Bill does. Maybe. I'll ask him. Bill, are you making your way to the podium to ask a question? No. Oh, he is. Okay, we have another question from Bill, who I've now called out.
Hi, Bill Gorash from University of Pittsburgh, and I enjoyed your talk as well. Actually, I thought that was an excellent question that she had asked, and I think that it's sort of the follow-through to that would be probably the worst thing that our government does not follow up on the outcomes of legislation that they've passed. And I think it sort of leads into that same situation, in other words, that scientists would also kind of need to really pay attention. It's not a one-time shot. In other words, it's a shot that it's a dynamic. So the person that's not drinking soda is drinking beer. So there's just lots of things that can happen, and it's very complex. And, in some cases, so it's just that, I guess I just wanted to just hear your thoughts on that side of it. In other words, even further than just paying attention to what's going on.
Well, thank you. It's a very good point. And it speaks to how important it is to have a connection between the policymakers and the scientists who are in the position to test just the kind of things you're talking about. And so you need to follow up to look for undesirable consequences like that. And then the policy, if it has such consequences, the policy can be abandoned or revised in some ways. Or a new policy might be better than the original one if, say, taxes on sugar-sweetened beverages overall have desirable effects. Yes, there might be some people who will switch to beer, but perhaps it's a minority and overall there's beneficial effects. Then you want government to follow through, to pass it in other localities, to perhaps increase the tax, and that's what's happening with tobacco taxes, for example, in such an effective way. Possible the tax could be applied to other parts of the food supply, not just sugar and sugar-sweetened beverages, but sugar and other things, for example. So there are a lot of ways that initial policy proposals need to be followed up on, exactly as you said. So it's a very good point. But sadly, what happens is that the policymakers and the scientists are often in different orbits, and they're just not interacting with one another. So policies get passed, and you have no idea whether in fact they work. And then the policymakers are not connected with the science, so they're doing things in uninformed ways sometimes. So bringing those two groups together, I think, would be very beneficial.
Yeah, I would think as well as to look at the real end outcomes as well. In other words, decreasing sugar consumption doesn't necessarily translate into a positive health outcome, in that particular scenario. So I guess that's what I think the scientists have to offer as well.
That's right, and there you face a really interesting challenge. Because, for example, some people say you need to prove that tax on sugar-sweetened beverages leads to reduced obesity. But there's so many things driving obesity that to expect any one narrow policy like that would affect prevalence is asking an awful lot. But what you would like to know is what happens to other parts of the diet as people are reducing sugar in these beverages. And if they substitute foods with more fat in them, for example, it could be that there's no benefit at all. And that's why I'm really happy that those kind of studies are being done. So you're right, we really need to hold policies feet to the fire in terms of evaluating them, but there have to be people or institutions stepping forward to fund those evaluations, or else they won't occur. Thank you.
Thank you very much.
We have another question, one more question.
Hi. I don't really have a question. I just have something I'd like to share. I live in upstate New York, and our hospital actually did something similar where they took all the good food and they lowered all the prices, the water, so it's super cheap, and then they took all the, chicken fingers, sodas, and all that and raised the prices. And the whole cafeteria is like that, and I think it's really, one, you save a ton of money, and two, you're eating very healthy. They also have farmers markets, and they can do payroll deduction. So our hospital really did a lot of this stuff, and I think it's a nice thing to do. I mean, it really makes a big difference. And then they label a lot of the food with like a green sticker for good food, so you can figure out what's good, and then red for not good food. So like a sandwich, you used to get chips, pretzels. Now they offer chips, pretzels, and apples. If you pick apples, your sandwich is cheaper. It's just really kind of a neat initiative. So I just thought I'd share that.
Thank you. That's a great
Thanks.
example. And it is an example of changing the information and the economic defaults in that particular institution. So that sounds great. Really nice to hear that kind of thing. Thank you.
Hello, my name is Christine Bauer from Hartford Memorial Hospital. And one thing, just in the same vein as she described, our hospital put color-coded ladles on the salad bar. So people think salads are healthy, but then they walk out with a salad that needs a crane to carry it. So what they did was they put color-coded pickups so that eat more of this, but don't eat the red one, a lot of the red color or the yellow color or the green color. So those are the three colors they use. So it helped you gauge how much cranberry craisins to put on versus goat cheese and then the lettuce or something of that nature. And it made people stop and think about it, and we saw a difference in that.
Well, thank you. Those two examples that people just offered are terrific. And they show that all the activity on this doesn't have to occur at the federal level, that sometimes things can happen very locally in an institution or a school or whatever, and then those things can expand and affect other people. So thank you, I appreciate that example.
You go. No, I don't have a question. Ask your question. I don't know. Karen was trying to pressure me to ask another question. I felt so on the spot, and there wasn't anything coming to me, but she has something to say.
All right, well, I just want to say two things. Number one, you started off this by talking about Duke and the basketball team and how they're number one in the country. So I have a 24-year-old son who loves Duke, and they don't usually talk too much to me, except if it's sports. And so I sent him a text message, and he actually responded. I told him what you had said, and he replied, "Well, are you surprised?" And then he went on to say, "Have the greatest coach to ever live and the best player in the country." So, anyways, I do want to take this opportunity to thank you for such a great presentation. We're very honored to have you here. And on behalf of ASMBS, I want to present you with this plaque that says, "Be it known the Society hereby recognizes and honors Kelly Brownell." Thank you very, very much.